And welcome back to the morning show. Dr. Umbach with, actually medical director of bariatric surgery at Desert Springs.
Gesundheit.
Thank you very much. Okay, now that that's all over with, how you doing?
I'm doing well.
Thanks for coming down this morning.
Oh, you're very welcome. Thank you for having me.
Absolutely. I see you brought a bunch of barbecue lighters with you today.
Yep. We'll go over these fun guys.
Well, now, all right, first of all, you've been in medicine a while.
Yes.
Internal medicine, obviously. What type of medicine do you practice?
Well, I'm a surgeon.
Okay.
I've been doing weight loss surgery for nearly 10 years.
Really?
Did a fellowship at USC, and in fellowship in advanced minimally invasive surgery is where I started doing weight loss surgery.
Okay.
And that's where we got to use these guys, but more importantly than using the fun toys is we got to see how powerful these operations were.
Now, what we're talking about basically, and everybody has seen it on TV or heard about it or read about it, and we all know people, I think, that have had some type of procedure done to where their intestines are clamped down or their stomach is clamped in half or whatever the case may be. There are numerous ways to go on this, are there not?
Right. There's all sorts of fancy names.
Okay. But do you practice one particular procedure more than another?
We do all the procedures.
Okay.
The most common ones out there are going to be the gastric band,
okay,
which is a band wrapped around the stomach,
okay,
and the gastric bypass, which is a way to reroute the intestines and bypass the majority of the stomach. So those are the most common ones. There's lots of other ones coming up. There's a gastric sleeve, there's duodenal switches, there's long limb gastric bypasses, short limb gastric bypasses, it goes on and on. But basically there's a gastric band and a gastric bypass.
Well, now, by the looks of these tools here, this would lead me to believe that a good bit of this is what they call arthroscopic.
It's all laparoscopic.
Laparoscopic.
Yep,
okay,
we do,
I'm sorry. Terminology.
We do about
suck.
5 cuts, about that big.
Oh,
that's it.
Okay.
I mean, you've cut yourself bigger in the kitchen, I'm sure.
Oh, absolutely,
Yeah.
all the time. Yeah. So these obviously are the tools. All right, you've got a stomach here,
right?
Or what looks to be a stomach. If you could, and this camera right
all
here
right.
is on it. Okay, this is what our stomach looks like.
Well,
that's a normal
this
stomach
is a small version. The problem we all have, you and I both, is that we've got a football. We've got a football for our stomachs, and we've got to fill that football up to feel satisfied.
Right.
Okay, so this is not a true size stomach. This is a kid's stomach, basically. Okay. What we do in these operations is we put on a device called a band, gastric band, lap band, realized band, all the same, and we create a small stomach pouch.
Now, this is the in here?
Yep, this is the in, and that's the big stomach, and then that's out through the intestines.
Okay.
And we create this small pouch now. Instead of having to fill that whole football to feel good and full, you got to fill this small pouch.
Okay.
By doing that, you eat less, you feel satisfied, and you leave the table. That's how this guy works. It's all restriction on the band. We just wrap this around the stomach. You can see how it clicks in place, and then we just lock it in place.
And you can do that all with these tools.
It's all laparoscopic. Yep.
Well, so then, now this is for what?
Well, the band consists of 3 parts. There's a balloon part here. I don't know if you can see that. It's squishy.
Right. Okay.
So, and then there's a tube where we blow up the balloon, and then there's a port. Everything is inside. Nothing's hanging out.
Okay.
Okay. Nothing's hanging out. And what we do is we put this in place in the operating room. You recover. Recovers fairly quickly. Most folks go back to work the next week. And you come back to clinic, and we start to fill up this balloon, pump it up to the right setting for you. And it's all individual. And we pump it up by taking a needle and putting it through this soft part, this plug, and filling this up with water.
And this is barely under your skin somewhere?
Yeah,
okay.
Just under your skin and your belly.
Okay.
So it's just a little needle. We do it in the clinic. It takes 5 minutes. It's virtually painless. So the band, one operation we do, has to be adjusted to work right.
Right.
And we see that fairly often. Folks go down to Mexico and get these things done.
Yeah.
And no one tells them it has to be adjusted to work right. So they come to us and say it's not working. And I said, have you ever been adjusted? And they, well, no one ever told me I had to be adjusted.
Oh my.
So it got to be adjusted to work right. So that's the gastric band.
Okay.
A balloon wrapped around the stomach, a tube, and a port. This is called a port.
So you're telling me that just filling up this little pocket right here, in fact, gives a person a feeling of being full. as opposed to filling this little football up with food and liquid.
Yeah, if you got to fill up a football, now I don't know, everyone's different. Some may be high school, some may be NFL regulation size. I don't know what you are. But if you fill up a football, that's a lot of food.
Yeah, no kidding.
This is not. This is a normal, healthy portion of food which fills up this guy.
Doctor, if I may, the pouch itself, we've had people tell us in our workout sessions that we should eat an amount of food about the size of our fist. If that were an adult-sized male, would that be about the size of the pouch?
Yeah, by the time you eat that food and chew it properly, it's get down to about the size of your fist. And you're right, you want to eat about the size of your palm there, size of a deck of cards, the gamblers, 2 to 4 ounces, that sort of thing. Otherwise, we'd have much bigger hands if we needed to eat more. So,
judging by
not like this, right, Sam?
I was going to say, judging by some of us, you think that we'd have 3 hands.
Right. Now, before I go any further, is this, and I would imagine, this is for anybody who obviously wants it, who can't seem to get back away from the table, who has an obese, they would be considered clinically obese. Is that right?
The term is actually pretty harsh. Severely morbid obese.
Morbidly obese.
Wow.
Okay.
Severe.
Severe.
Yeah, it's pretty harsh term.
So for a person who ought to be about 200 pounds and they're actually up to how much weight? What, another 100 pounds, if they were 300 pounds, would that be considered?
Basically, by the time you're 60, for women, about 60 pounds over your ideal body weight.
Okay.
For men, about 80 pounds maybe over your ideal body weight.
Okay.
That's when we start to consider doing these things. That's when.
There is, okay, it seems, oh gosh, I'm going to have this in my stomach, and I'm very uncertain about it. I'm assuming through the trials and tribulations, this isn't something that just came out yesterday. It's been used for years.
Right.
I'm assuming the safety and the benefit of this far outweighs not using it and continuing on because of the heart problem, the joint problem, and everything else, the diabetes and everything that goes along with overeating.
That's why I do this procedure. Because I was a general surgeon. I did do general surgery, and I took care of all the complications for those diseases after they happened, which of course is too late. It's like getting to the fire after it's burned the house down.
Right.
With this operation, we can prevent these problems from coming. So that's why I do it, because I can do one operation, and oftentimes I can cure 3 to 4 diseases in a single person. That's how powerful this is. Diabetics have about 70% chance of getting off all their medications. People with sleep apnea, mask, they have about a 90% chance of getting off that mask. I mean, this is incredible odds.
I guess.
Incredible.
Now, is this considered, this little collar and thingy here, that's considered state-of-the-art for right now?
Right. There is some stuff coming down the pike, which we can do entirely through the mouth, so we wouldn't be able to use our fancy instruments anymore.
Wow.
We'd have different ones through the mouth. But it's still experimental.
Yeah.
And they're probably not going to replace what we do now. They'll just add to our abilities to offer other people options.
Okay, doctor, it sounds like there's a lot of positives to this, and I'm sure there are, because you can obviously see them. Is there a downside to this?
Absolutely. It's a lot of work. I mean, this isn't a magic ring. It's not Frodo's magic ring, unfortunately. I wish it were. And it takes a lot of effort for people to get these surgeries. First of all, it costs a lot. The insurance companies have a lot of requirements in order for them to pay for it. And after you get the surgery, you still have to work as well. You have to change lifestyle habits, add that E word, exercise into your life, follow up with me or another surgeon periodically. So it takes a lot of work. It truly is a life-changing event to get one of these.
Well, I would imagine after that is on, the band is on,